It may not look like spring outside, but be thankful you're not in Boston today where they're going to get a foot of snow and have flooding, I guess. I'm Rich Vehe, the director of the Division of Pediatric Rheumatology. This is our public website if you want to know more about anything going on in our division or the people of our division. And this is my disclosure, but my real disclosure is that I'm a rheumatologist and I like informatics, so this could be painful, and I apologize for that. So today's goals are to help you be able to describe the current state of evaluation and care of pediatric rheumatology patients, the key trends propelling improvement in evaluation and care, and opportunities to get involved and make a difference. And I thought I would start with a typical case. This is actually, the start of this is a real case that was recently referred to us. And this is a very common scenario. So a 2-year-old walks into your clinic. They've had 1 month of swelling and warmth of one knee. They're completely asymptomatic after their brief struggle in the morning. So in the morning, they're a bit stiff and they walk stiff-legged, but then the rest of the day seems fine, sleeps well at night. No recent illnesses, nothing like this before, nothing in their past medical history that's suspicious, and nothing in their family history. So the evaluation process for rheumatic diseases is similar to other specialties, and it really hasn't changed much in decades. And this is one of the areas where we need improvement. We start with a history, we do a physical examination, we make an assessment and plan. And oftentimes, individuals think that there's a need to do something more than an assessment in order to make a plan, but there really isn't. There are times when you need imaging, there are times when you need laboratory studies, there are times when you need to make a phone call to be sure you're on the right track. And one thing that's often missing is initial management. There are simple and safe things that can be done for most patients. The process is really pretty straightforward. In rheumatology, thorough history and physical will identify the likely diseases and focus testing. And in our specialty, it's especially important to try to identify the location of the problem so that the diagnostic considerations are simplified. And it gets a bit complicated because we deal a lot with joints. We have multi-system diseases, but we especially deal with joints. And what's going on at the joint may or may not actually be in the joint. So we have two bones that join together. They're held together by a joint capsule as well as ligaments. On the ends of the bones, you have cartilage, and all these structures can be the source of problems. The joint capsule is lined by synovium, as are the tendons and the bursa. Bursas are cushions between tendons and bones that reduce friction. All these synovial structures can get infected or inflamed or invaded by malignant cells. We have muscles, blood vessels, skin, and nerves, all that can be a source of symptoms. So to the extent we can at least identify, is it in the joint capsule? Is it outside the joint capsule? Does it seem more like it's in the bone itself or another structure is very helpful. And so the next thing to consider is, as you're doing this, what don't I want to miss? And we want to be sure not to miss unstable bone or soft tissue injuries, local and systemic infections, and then other life-threatening illnesses such as malignancies or multi-organ vasculitis that could have dire outcomes. If it's just joints that are a problem, we usually think about injuries and infections for acute problems. So there's two I's to remember: injuries and infections. That's what kids are about. They jump off things that are too high for them and they break things, and they get infections a lot. If it's chronic or chronically recurrent, then injuries are still high on the list, and infection drops lower, although not impossible. There are cases of Lyme disease which look relatively chronic, but more often we're dealing with idiopathic inflammatory disorders that are autoimmune, or the newer group of disorders known as autoinflammatory disorders. And of these, the most common are the things now called juvenile idiopathic arthritis, which is a whole nother area of difficulty and in need of an area in need of improvement. So for the typical 2-year-old that walks in, you go through, you do the exam, and you might find that the child basically looks fine by the time they got to your clinic in the afternoon, because you're not at their house at 7 in the morning. And this is your exam. And so our assessment would be an otherwise well 2-year-old with a 1-month history of arthritis. And you might say, how do we know that's arthritis? Because if the swelling is limited to the joint capsule, and you have swelling or you have a combination of other features, including warmth, in the historical information of stiffness after rest, that is what is consistent with arthritis. And serious infection and serious injuries need to be considered, but are unlikely given this story. This is a well child. Still, you need to go a little bit further. If it's that swollen, you can't just send them home. So you, instead, though, we mostly end up with this. We get an assessment that is vague. The family came in reporting swelling, and the assessment provider is there's swelling, but they don't say where the swelling is, and they don't even include a differential diagnosis, and yet they go off and order many labs, including labs that I didn't even know you could get. And they do imaging that often requires general anesthesia, and they do procedures that are highly invasive, or even send kids multiple states away to get procedures done for things that are terribly unlikely to be the cause of the problem. And then there's no advice given for how to manage until the next step, or it's erroneous advice. So needless to say, there's a lot of room for improvement here. So let me go into I was asked to provide 3 questions for the viewers outside, and I'll go through 3 of these. One is the first question about imaging. So a relatively painless swelling is an uncommon presentation of chronic arthritis in a 2-year-old and should prompt MRI of an affected joint. So go ahead and think through that. You can make a note to yourself. A, true, you should get an MRI, and a plain MRI, as done by orthopedics as a standard procedure, is the way to go. True, but you should do a double study, both a plain study and a contrast, IV contrast study, the way rheumatologists like to do it. Or C, neither of those. You just don't need the MRI. The point of imaging is to get information about location, process, and priority. And really the starting point should be bilateral plane radiographs. And they're almost always a good idea, and they're almost always uninformative. That is, they don't have a positive finding. They're only a negative finding in that they don't show anything. And the reason for bilateral is illustrated by a recent case. The outside radiologist, who I don't think did pediatrics, reviewed the single limb and wrote this wording in the assessment: irregularity of the medial femoral epiphyseal cortex. And that's the arrow. This is not actually the child. This is from the 0.3 second Google search I did. And this radiograph is actually from the first reference. And the second reference has this text in it, which is irregular ossification of the distal femoral epiphysis is a common observation and frequently bilateral. And really there's only one major thing in the differential diagnosis, which was not what the reading radiologist put in that note, and this child ended up going down a pathway that was unnecessary. So radiographs are a good place to start. If you don't know where the problem is, if you can't localize it, a bone scan is helpful, despite the fact that kids have hot epiphyses that light up. One of the big things that's changing, and the residents might be particularly interested in this, is real-time ultrasound in clinic is becoming a more common trend. It really took off in the private world, but it's now worked its way into academic centers, and pediatric rheumatology centers are doing this. And the training is actually readily available through our specialty. And so if you're in clinic and you have a question about something, just like the residents do in our ER here, you pull out an ultrasound machine and you figure it out. It's a little tricky to do it in kids because of the vascularity issues with development, but it's proving to be a very useful tool. The real utility of MRI is when you know where the problem is, but you're not absolutely sure what the problem is. It will give you the most detail possible, but the problem with a 2-year-old is you need general anesthesia to do it. So for this child, generally the starting point would be just to do plain radiographs, and you don't need to race to an MRI. In terms of the x-rays will give you information about injuries, whether it's traumatic injuries or malignant injuries or infectious injuries. Again, not 100% sensitivity, not even close to that, but it'll give you some good starting information. The next question is it inflammation or not? And that's simple too. You don't have to order exotic labs. You can start with these basics. And so people usually are sticking a kid and they want to know, well, what else should I consider? And around here, we certainly should keep Lyme disease in mind. And so let me ask you a question about Lyme disease labs, again, prompted by a recent referral we had. For a patient with a relevant exposure history and symptoms typical of Lyme disease, the ideal starting test, if feasible, is which of the following? Should you do PCR on the blood? Should you do serology on the fluid from the joint? Or should you do serology on the blood? Okay, think about that. What this patient actually had done was PCR on the blood. But you can just go to the CDC website and see this statement that PCR provides highly specific evidence when obtained from a variety of samples, but it's actually pretty poor on blood. So this patient had no serology done, did not have PCR on the joint fluid, which again wouldn't be my starting point anyway, but they did PCR on the blood and then jumped to the conclusion that they had excluded the possibility of Lyme disease. You might consider a whole bunch of other infections. You might wonder what else needs to be done. Certainly we need to keep strep in mind. We want to know if it's in the throat, if there's been an immune response. And parvovirus causes some interesting outbreaks of arthritis that in children looks nothing like adults. Adults often have a polyarthritis, looks like a rheumatoid arthritis, but kids will do anything they want. Kids don't read textbooks very well. If they have a fever, you certainly want to get a blood culture. You certainly need to consider whether or not you need to tap the joint. You may need to consider whether you need to get some bone tissue because it could be an osteomyelitis. And this is one of the times where it's really important to consider an MRI before you go to do a procedure, is where is the right place to sample. So if you have a child who's febrile with marked inflammation and exquisite tenderness, you're going to probably image and then take them straight to the OR and do the procedure. Not you, but the orthopedist will. But I still haven't mentioned anything about those Rheum labs. And people want to order these up front, and these lead to a huge number of referrals for us, which is great if you're building a practice, but otherwise isn't particularly good for the kids or their parents who go on to Google and read that their 2-year-old is dying of lupus. And in fact, it's incredibly unlikely that a 2-year-old would have lupus. So for a 2-year-old with arthritis, with or without fevers, an ANA is an important screening test for juvenile idiopathic arthritis. Is that true? And you should do then the reflex testing, because an ANA is a screen, and then there are specific anti-nuclear antibodies, anti-double-strand DNA, and the rest of it, which is in the extractable nuclear antigen panel, or E for everything else. Or should you get a rheumatoid factor in an ANA, or should you just not bother with that in this setting? Well, you may have figured out by now everything is false this morning that I'm saying. This is the old definition for JRA. JRA was called JCA in Europe, and these criteria explain, in a sense, why it was called JCA. The new term is JIA worldwide, and these criteria explain that as well. And you'll notice there are no labs in here whatsoever. And this is both the beauty and the hassle of these criteria. These criteria have not changed in decades. The names have changed, but the criteria have not changed, and we're not moving along very fast at moving the field forward and doing a better job for these kids. So if you're a kid who has had arthritis for 6 weeks or more, and arthritis has a standard definition in all our clinical trials, but you don't have something else, you get called this. And so if you can't think of other things, you may overlook important things that really are mimics. So there is no need for any of those serologic tests. If you're going to do anything else, I'd be interested, especially in a kid who appears ill. I would want to know about their liver and their kidneys. Is this going to turn out to be a multi-organ disease? Am I going to use meds that I need to know about liver and kidney function before I start these meds? And then in terms of management, you can always do simple things. I think we all learned RICE. You can rest it, you can ice it, compress it, elevate it, and you can do a pain reliever or even an NSAID. If the child might have IBD or has been vomiting, an NSAID may not be possible. But these are all pretty safe to do. The thing with rest is if you can, ortho likes to cast, and casting does make a swollen joint feel better. It protects it. You can sleep because it's now not going to get bumped when you roll over in your sleep. But it's nicer if you can put on a splint that goes on and off and allow the child to stretch and as well as to bathe. So in theory, we would just typically say, get some radiographs, get a CBC, CRP, sed rate, consider relevant infectious diseases. If there were some features that really bothered you, a presentation of malignancy that we worry about is waking up in the middle of the night with pain. Happens with arthritis, but we worry about some more ominous things. And then do these things, and in the next day or two, we'll get back to you as to what the next steps are. But like I said, instead, we get things like in the last couple of weeks, I've had rheumatoid factors done on synovial fluid, the Lyme PCR on blood. We've had hospitalizations. We've had imaging that was unnecessary without considering really first-line possibilities. So the bottom line is there's tons of room for improvement in both classification, diagnosis, and in management. So let's go on to where things are going in our field. And this is where I think I'm pretty optimistic, and I think it's pretty exciting. So I sort of stole part of a quote that I think is relevant, which is when you're trying to figure out what's wrong and how to improve it, you really should start in concentric circles around your own desk. And I've been trying for decades to do talks and teach residents. And while I can see a change over time in sort of the workups that are done in primary clinics or ortho clinics, it hasn't gone as far as I'd like. We're still getting a lot of referrals that I think we've failed these kids. So the part of the problem is there's only so much you can do as an individual. There's about 300 of us who are active in the U.S. We're mostly based at medical schools. We're not out there in the communities. And there are entire regions of the country that still don't have anyone. So what we did was we started with the idea of, well, we need to get some talented people in here. So I had the good fortune of hiring Bryce Binstead with John Schreiber doing a lot of arm twisting to get him here. And we set off to start a fellowship. And we got a challenge grant from the Wowsy Foundation. We knew someone at the Wowsy Foundation. And the fellowship started. And the net result is that we've grown tremendously since 2009 when the fellowship started. And in fact, we've grown so fast that I can't keep pictures current, so I have to splice in one more picture because we now have Kristen Wu as our second research coordinator. But we have 6 physicians, 2 nurses, a care coordinator, 2 research coordinators, an education administrative assistant, and an administrative assistant. And with talented people like this, they started having great ideas. So one of the things Colleen came up with, Colleen Perel is on our faculty, she was our 3rd fellow, she came up with the idea of looking at what is being done by the primary pediatricians in terms of use of laboratory studies and how can we help with that. And she followed, or she had in addition the other idea of looking at what are the barriers to getting patients into the right clinics. One of the things we see often is that the kids are sent in the wrong direction to the wrong specialty. She then was mentoring Danielle. Danielle Bullock was our 4th fellow and has joined the faculty now. And she looked at telemedicine and to try to get parents' perceptions of whether this is a good idea or not. And it was rather interesting because we have families coming from as far as Montana, and it's surprising that families are not as excited about telemedicine as in-person visits and hands-on visits. And I find this particularly interesting that we got information about this because last fall this editorial came out, or this commentary came out in JPEDS, and it talked about the shortage of specialists as well as the problems facing primary care physicians and how the specialists need to reinvest in helping the kids have a medical home with their primary care physicians. But the primary care physicians are, from what I've been told, are feeling more overwhelmed and are actually referring more patients into specialists. So this is an interesting dynamic that's going on where people want to go to the specialists. The primaries may or may not want to be able to keep them, but these patients are pushing to leave. We would like to push them back. Not everyone needs to rush in. I think every specialist has their referrals that they go, gosh, this really could have stayed in your primary clinic. When you're thinking about all these problems locally, though, you have to have situational awareness, and you have to know what's coming behind you and what might crash down on you. And that's where I think the real excitement is in our field. It may not seem exciting to the oncologists in the audience or some of the other specialists where they have a field that's moved along quickly. Our field has been lagging, but there are some really interesting trends right now that look like they will change things substantially for us. And these revolve around these topics: partnerships and teamwork, learning systems. That is, you have individuals who are interested, but they may not have the skill set, so you build learning systems to bring everyone up to speed and be more capable. The use of information systems that provide feedback into these learning systems and allow for the tracking of data. And then through all this, we have a reconsideration of classification, evaluation, and management going on. And those are all long overdue. So let me just briefly expand on the second half of that last slide. With classification, what's happening is a push towards molecular taxonomy. Now, that wouldn't be a surprise to oncologists. They have very specific ways of characterizing malignancies they're dealing with. For most of us dealing with infections, we know it maybe by name, but an infectious disease specialist knows all the characteristics of the particular strain the patient has and what the pros and cons are of different therapies. So we want to get to molecular taxonomy so that we really can be smarter about classification as well as therapy. And what we're learning is that we have a lot of diseases that we called autoimmune diseases that aren't. They're autoinflammatory. So we have inflammatory pathways in our body that can get set off and run out of control with deadly consequences, and they're not due to the immune system malfunctioning. So it's important to understand there's a difference and that there is a requirement for different approaches. The autoinflammatory disorders tend to be specifically monogenic and have more specific interventions in some cases. There are big changes going with imaging. As I said, I think real-time imaging in the clinic is a big thing. With the molecular taxonomy approach, there are new biomarkers and genetic testing for diagnosis and management. The management now is very much more molecular. Our patients come in who have received some of our newer therapies and use the word miracle to describe how different it was within a day of starting a new therapy. And that's a big change from the therapies we used in the past where we caution them it could take 6 to 12 weeks to see full benefit. There's a big movement in our field, and I assume in others, about treat to target. I don't find treat to target to be a new idea. The idea is fully understand your patient's circumstances, understand their disease, understand the problems that can come with the therapy that you recommend, a treatment plan, the long-term prognosis, and address all those issues. But now it's called treat to target. And the big change that's happening with this treat to target now in our field is the patient and parent-centered goals. The way I'm going to come back to all those topics, but I'm going to do it through talking about the partners that we have and where the progress is occurring. And I will touch on how it's impacting education, care, and research. And these are the partners I will talk about. There are more than this. You'll see a few references on slides, but I won't talk about the others in detail. So the American College of Rheumatology is our big thing. We're a minority within it because it's mostly adult providers. If you go to the national meeting in Chicago this year, you would be among 15,000 people from around the world. It's an exciting educational event in which there's tons of scientific breakthroughs and therapeutic breakthroughs announced, and new products miraculously have FDA approval right around that time every year. And you might say, why would I go to this? Well, if you're a resident, you might go to it because you have an interest in rheumatology and because it would be a free trip. So just so you know, the American College of Rheumatology makes it possible for people of all levels to attend, including students and residents. So the American College of Rheumatology does a variety of things that other specialties organizations do. They have a publication series. They have these educational programs. They publish guidelines. They provide information for patients, and they do policy work. The way they foster a lot of their things where they're incentivizing people to contribute is through their foundation. And their foundation has funding for education, training, and research. And you don't have to be a rheumatologist to do this. And this is where the list of awards is quite lengthy, but it includes everything from visiting professorships to students and residents doing research experiences, going to national meetings at the American College of Rheumatology's expense, as well as young and senior investigator awards. So there's a tremendous portfolio of resources here. If you want to know more about the RRF, Bryce Benstead is one of the significant leaders within the RRF, and he'd be the most informed person to tell you about opportunities. Another thing I said they do is they do guidelines. This is the 2013 update on management of juvenile idiopathic arthritis. So there's a literature review that occurs. The fellows play a role in doing this, and the faculty put it together. They continue to revise these. We're in the midst of a 2018 update, and this is the process they go through to get to a final product. But of course, you can only do this if you have products, and the products have to get approved. So that's where the second network comes in. The Pediatric Rheumatology Collaborative Study Group is the group that does these studies, and these are the centers around North America. We're the only center in Minnesota that is participating in these studies, and we have several studies going on with them. And so this collaborative includes a centralized coordinating center. They've developed and validated the tools we use for JIA research, and they're now getting into other diseases, including lupus and vasculitis. And they've developed research protocols that are attractive. So we don't do many double-blinded studies. That is, everyone gets active therapy at first, and then they go through a randomized withdrawal phase. So it's attractive to everyone. They then, if they flare, they can go back onto active product. And importantly, this network provides training for physicians, and increasingly now fellows are welcome to be members of this and get the training. And the need for this organization has expanded tremendously. It developed in the 70s, but it's really taken off with all the biologic products that have come on board in the last 20 years. So because there's such a need, it's now led to a partnership with the European consortium, or I should say the rest of the world consortium. It's based out of Genoa, but it really involves multiple continents. And there are daily discussions, I'm told, between PRCSG and Printo over studies that are occurring internationally. This is an example of some of the studies that are going on. We have studies of vasculitis, studies of lupus, and multiple studies of juvenile arthritis. You see some of under the main menu, you see some of the resources that are available to individuals, including families. You'll notice on the far right that all of these are sponsored studies by pharmaceutical firms. And that's important. We need to get products to market. But that's not enough. So we actually have yet another network. And this is called the Childhood Arthritis and Rheumatology Research Alliance. And this is another one we're highly active in. And this is one that does investigator-initiated and patient-driven research. Its vision was to provide a mechanism by which all kids could be in protocols. So it was modeled on those other successful networks. And the nice thing was we could start from scratch as opposed to have competing things that you had to merge leadership on or vision on. So it has a large registry that provides large data sets of de-identified clinical information for uncommon conditions. And it's incorporating a biosample bank so that we can have relevant samples for investigators in the field as well as outside the field. And it's built the infrastructure to support this, and it's really rapidly growing. We're participants in the registry. We're currently the fourth highest enroller. It's a pretty tight group there, third through sixth, but our coordinators here do a fabulous job of identifying patients who should be in the registry and getting them signed up. This is sort of the scope of their major products. The registry is the first thing. The original purpose, as I said, was to be able to facilitate research. It's now been expanded that it can be used by industry for post-marketing surveillance. They're mandated to follow up on their products, and we provide the mechanism by which they can do that for a fee, which makes the network then supported in part by industry. We have developed, as a group, the fellows in the room, the faculty in the room, and it blows the fellows away to sit in a room and think that they're going to be asked their opinion, but we've developed consensus treatment plans for a variety of diseases, and those are now being used for comparative effectiveness studies. So the registry itself can be mined for data. There's a variety of grant mechanisms for mining, and there's training opportunities, including training. Dr. Carrel will be going to Utrecht this year, correct? Oh, you're going to Amsterdam, I'm sorry. And so there's training inside and outside the country available for individuals. There's publication support, there's training of coordinators, and there are registry internships in which individuals can learn how to mine the data and actually get some informatics training. But the consensus treatment plans allow us to do the pragmatic clinical trials. And if you're not familiar with pragmatic trials, the idea is to take research directly into the clinic. Instead of having randomized studies where you carefully screen patients and exclude patients, you're now allowing virtually everyone who walks into a clinic to be part of a research trial. And so for us, this is a recent review of how these consensus treatment plans are being used for comparative effectiveness trials. And this abstract explains it in brief, which is what you do is you develop a consensus treatment plan in which you've simplified the choices and you come to consensus as to what would be a reasonable way to prescribe methotrexate. What's a reasonable way to use steroids? When we've done surveys of how people do things, everyone has a subtle difference that's probably not meaningful in how they do things. So it's impossible to aggregate data and do studies. Everything is so continually different. So what they've done is simplified it, and you can decide whether it makes sense to use one of these for a patient, and you enroll them, and you then collect the data, and through some sophisticated analysis, they can determine comparative effectiveness. So one of those studies is one called Stop JIA, and again, we are just taking care of patients the way we normally would. And if the therapy seems to resemble one of the arms of the treatment, we can enroll them. And again, we're enrolling patients. This is newer. You can see the numbers are much smaller. Another area of research is randomized clinical trials. This is new. This was the province previously of PRCSG, but through collaboration between the two, there's now a study of Still's disease or systemic onset JIA and adult onset Still's disease to get FDA approval for a product that's long been used but has never been labeled. The other thing that's going on is there's a large group of studies going on around patients and their preferences. So we have the pro-validation, the patient-reported outcome validation study called PEPPER, patient engagement work, and the co-production of healthcare effort through Dartmouth. And PEPPER, again, is one where patients are answering questions on a tablet and providing information about their preferences and their impressions of their care. And it includes pedometers to measure their activity as well. And we're actively participating in that. And again, our coordinators are doing a great job of enrolling kids. Translational work is another major area of work, and this is where we should have been decades ago. We have genetic data that said we should have reclassified diseases even back in the late 80s and early 90s, and it hasn't happened. Ray Young is at Toronto Sick Children's and has been a leader in translational research. She and colleagues in the US, Canada, the Netherlands, and England have been working to standardize procedures so that as we collect data, it actually is analyzable without variation in technique that makes conclusions from one batch of samples unreliable. So this is a general model for translational translational research. I think you're probably all familiar with it. You have to build out a lot of infrastructure on the left. You do clinical research and collect all that data, and then the output, the hope for, is new therapeutic approaches, new diagnostic approaches, and new disease classifications. And we're finally getting to that point. And this is an example from the adult literature talking about this term I introduced earlier, molecular taxonomy of autoimmune diseases. Their bullets, make the point that I hope was clear already, that our current diagnostic criteria are ambiguous, generic, or difficult to assess and lead potentially to misdiagnosis or leave patients unclearly labeled. That there is evidence, long been evidence, that there are disorders that are similar and need to be classified together, and disorders that are separate and need to be split apart. And there are a lot of benefits in the long run that would come out of this approach as outlined here. So precision medicine is finally coming to rheumatology. And this is just one example from the adult diseases. I had a discussion a few weeks ago in the hallway with one of our nephrologists, lamenting the good old days when nephritis was simple to classify. And nephritis is becoming increasingly complex, just as our rheumatic diseases are. So we've long known that adult rheumatoid arthritis is not a disease. We talk about it as a disease, but there are these flavors within it. And there are individuals you just go, no, this isn't going to work. I just know this isn't going to work for this patient. I've seen this before. And they really can be distinguished on a molecular basis. They need to be distinguished, and we need to move forward with rational therapy for these individuals. So that's where we're going with on a molecular basis. The final thing I want to just mention is our other major project we're involved with is PRCOIN, which is the Pediatric Rheumatology Care and Outcome Improvement Network. And this is an outgrowth of the American Board of Pediatrics' big initiative about 12 to 15 years ago to transform the way care is delivered in the way pediatric subspecialists practice. So maintenance of certification, the bane of many physicians' existence, includes a Part 4, which is quality improvement. And many of the Part 4 efforts have been kind of mind-numbingly, seemingly pointless. But it provided an opportunity to really build out networks. And so the American Board of Pediatrics laid out this vision of national databases and registries that would lead to collaborative improvement. And ours that came out of that is PRCOIN. And again, if you get your annual mailing from the American Board of Pediatrics, you see things like this, talking about the need for improvement. And then especially in the last few years, and this is 2 or 3 years old, I think this is 2016, talking about the input needed from families. And their message is that parental guidance is advisable. And we recently at a PRCOIN meeting were given a multi-page handout of quotes of parents who have been involved with the American Board of Pediatrics or are parents of kids with juvenile arthritis. And there are a number of incendiary comments in there and almost depressing comments about the way some families have been treated. I think this one was a nice statement. And I think it's one that's hard to argue with, which is our only expectation is that our physician understands that living with a chronic illness is riddled with stress and burden, and to address mental health from the onset, because it's crucial in reducing these issues. Our ultimate goal should always be to have a happy and healthy child. And we know this is an issue that's been under-addressed. So this is what the PRCOIN website looks like. It gives you an idea of stuff they have for physicians, for families, the resources they have, talking about how it's built out and how it's linked to other entities. On the lower left, you see it have PRCOIN. PRCOIN has a tight working relationship with CARRA. CARRA is funded in part by the Arthritis Foundation. The Lupus Foundation is a partner. And the dermatomyositis and inflammatory myositis disorders fall under the CURE-JM, juvenile myositis umbrella. And all these together have been pulled administratively or for networking purposes into something abbreviated partners. And this has been possible through the funding of the initiatives that came out of the Affordable Care Act, including PCORI. So that's what's going on in the U.S. The same thing is going on worldwide. This is an article a review that recently came out, talked about one called SHARE. share is the single hub and access point for pediatric rheumatology in Europe, and I expect that the two will end up linking up as well to do work. One of the things we've learned, though, is quality improvement is not enough, and this actually came out of one of our recent training sessions for quality improvement. And the point made by Dwayne Spencer was that so you have to understand this network is based at Cincinnati, and I think he was making a jab at Cincinnati Children's having deep pockets when he said this. They've spent a ton of money on quality improvement, and they really are leaders in quality improvement. They're a fabulous resource to pediatrics, but there's now thought that you have to do this smartly. And lean, he went through and explained the process of lean, which many of us think of as something where you're just going to cut people out. But that's not what lean is actually about when you get into it. It's more about how to get maximum results out of the resources you commit. And one of the ways our field has done that is some of the people in PRCoin, myself not included, developed something that can be used in Epic where you can put the data in during a routine clinic visit, and the data then ends up in your note, or conversely, at Stanford, they put it in their note and it populates the forms in Epic, and all this data is automatically uploaded to a national database, and then you can benchmark yourself against your group and benchmark yourself against other centers doing quality improvement. So that's a very smart thing. Build it into your workflow, not much extra work. There might be more fields on a form than you normally would do, or you might have a note that's a little more complicated than you might have originally because you're putting quality measures directly into your note. But the idea is to just make this part of the natural way of doing business. And recently, like I warned earlier, I have an interest in informatics. Recently, I saw a presentation at a meeting at Epic that really surprised me, because this is a group that had several presentations, and they took that idea to a new level. So they described how they use clinical documentation and smart sets and decision support tools for quality improvement. And this is their laundry list of what the benefits were. So I'll spare you the multiple talks they gave, but what they did was they took 41 neurologists and they got them to agree on the evaluation and management of common things. There's a lack of standardization for how many of these meds are used, or how far should you go on imaging for someone who has a migraine headache? Does everyone need an MRI? Does no one need an MRI? So they came up with an agreement as to best practices, and they built it into their EMR. And that allowed to build efficiency in. It allowed them to capture data for quality improvement purposes. They started to look at their processes and their outcome measures. They started to distribute, okay, who's going to do what? The rooming staff does this. This patient does this before they even check in. This is done by the nurses. They distributed all the tasks out to make it a really highly functioning process for these individuals. They had the nice advantage that their notes were so complete, they bumped up to level 5 billing, so they had a nice revenue stream that the system appreciated. Their notes were being generated so quickly that they improved communication to the community doctors, and so that built out loyalty. And they started building in, again, pragmatic trials and learning what therapies actually work. People have opinions as to what's best. Everyone has a personal style. Let's get some data and really prove it. And they found it even helpful in terms of education and in building out things nationally. They educated their peers around the country, and they have buy-in from other places. I will say there's one drawback to this kind of process, and it's been discussed at these meetings. When you hardwire things into the EMR, about how we do business, how we take care of patients, we sometimes lose the ability to think. And there have been examples of people not knowing how to write admission orders anymore, even. I mean, we used to all know that. We had a mnemonic for it or a card in our pocket. But now, if Epic's down, do you know how to write admission orders? What's in a complete set of orders? And they have examples of where people just assume that if a box is checked, it should be used, and you think the computer is smart enough to figure out, but really you can't do a 6-minute timed walking test on a 2-month-old. And when that's pre-checked and keeps slipping through repeatedly, you know you've got a problem with EMRs not being quite up to snuff and being smart allies. So let me wrap up. The current state of evaluation and care of pediatric rheumatology patients leaves a lot of room for improvement, but I'm optimistic that we have some key trends that will transform the way care is delivered and the way we practice. And my hope is that it will actually simplify the approach to diagnosis and management, that we will have very simple, straightforward schemes that are not weird diagnostic criteria. It's this if it's not something else criteria. Seems backwards. There's tons of opportunities to participate. Students can do research projects and go to meetings. Residents can do research projects and go to meetings. They can do electives with us. Fellows have the opportunity to go to meetings, participate actively in the meetings, and really travel everywhere they want to go, because there are meetings all over the world. And investigators have an amazing availability of information to be explored. And that's true whether you're a rheumatologist or your interest is in behavioral pediatrics or adolescent development or infectious diseases, anything. There's a willing partner somewhere, and we have the organizations that we can say, I think this kind of idea, we would route it through this group, and we have a research intake. We'll take your proposal and provide suggestions and help you shape a winning proposal. So that's my opinion. To quote Dennis Miller, I could be wrong. But that's all I have for you today. We'll finish a little bit early. I'm glad to take any questions if you have any. I'll wait for the mic. Uh-oh. You lost out.
So, Rich, one of the things that's particularly challenging about industry specialty partnerships is wending your way towards effective partnership while avoiding conflict of interest. Can you say a little bit about how your organizations have threaded that needle?
The PRCSG long ago decided that industry studies need to be shaped in a way that meet the scientific goals of rigorous study as well as meet the needs of patients and parents. We still occasionally get approached by companies that want to do studies, and I don't know of anyone who will participate in a study that is offered directly up from the company. I'm not against industry, but I just don't think they understand that it's the usual complaint in pediatrics. They just don't understand what we think is reasonable. So PRCSG not only developed the tools to determine what is the definition of improvement and what should we be aiming for, but they've been very careful to push back hard and make sure that these studies are scientifically rigorous, ethical, and desirable. So there's always, our IRB is very careful to make sure how we present studies. And I wouldn't say we're a high enrolling sites for these industry studies. We meet our goals, which we set very low because I never want to twist anyone's arm. I want parents to always do what's in the best interest of their child. The reason I like these studies is I get access to products that I know they're usually already approved for adults. There are very few where we're doing them at the same time as kids, in the kid study as adults. And so we know that there's 3, 4, 5 years of real world experience, and some of the bugs have been identified with products, and we can say, this is probably a good idea given what your child has tried so far. Why don't you consider this now? Because, and many of these require, they're not designed for people fresh to the clinic. You have to have shown that you've got arthritis that or another condition that has legs and it's going to continue and really needs a novel intervention. Does that help?
It's just a very different set of circumstances, and it's a big struggle
Yeah.
in genetics because all therapies are new.
Yeah.
It's a big struggle in genetics because all therapies are new, all patients are naive to their condition, and all things are in very early stages of development. And so,
Right.
and
They don't do them
lots
in
and
adults
lots
first.
and lots of money to be made with orphan products. So
Yeah.
there's a lot of what I would call piracy and exploitative
Yeah.
opportunities that you have to avoid.
Yeah, I can see your point completely that you're in a very different situation where you may not have something may sound too good to be true, and it might be, or it might be terrible, and the patients are being exploited with false hope.
Yeah, well, there's all these miracle plans, and yeah.
That's the interesting thing is with the modern therapies we have, many kids do talk about them being miracles. The problem is we still can't identify the 30% that don't respond to a product. So you'll have 100 kids, 70 respond to product A, whereas they didn't have control with anything else we were using. But 30% don't. So then you try product B, which is in a different category. 70% respond, but it's a different 70%. Why is that? We need to get answers as to who deserves what therapy and why. Dr. Neglia had a question.
So a little bit different question. Several years ago, I don't know, 5, 6, 7 years ago, you had put up a slide at one point that talked about the number of children with rheumatologic disease that were being taken care of by adult rheumatologists as opposed to pediatric rheumatologists. And that was part of the reason for expanding the division, trying to change that. So 2 questions. Have you changed that percentage? Do you know? And then do you have any information on the difference in management of children by pediatric rheumatologists versus the same illness by an adult rheumatologist?
Yeah, so as we've added people, our numbers have just gone up. We haven't diluted the same number of patients. We have an increased number of patients every time we add a physician to our group. I don't know of a more recent survey. Dr. Carrel, our epidemiologist, might know of something more recent in this regard, but it's about 50% of the patients are getting care elsewhere, outside of peds rheumatology. And there is data comparing, I don't know the depth of it, but I've seen data presented about the differences between pediatric and adult rheumatology practice styles for given diagnoses. That is, what percentage of some of this, we get some data about this already in our field. We can see, like our center, what our tendencies are compared to other centers. But there's similar data comparing pediatrics and adult. I don't remember exactly where that's from. Colleen might know, but they really do practice differently than we do. One of the reasons the American College of Rheumatology does these literature reviews and publishes guidelines is specifically to try to make it more straightforward because they know that their members, who are predominantly adult rheumatologists, are providing a lot of this care. So again, they're looking out for the patient's interests and the provider's interest by these papers are full of dense text, but importantly, they have figures that anyone can understand. You just, start here and follow down and you have a pathway for management. And it tells you at what time each switch should be considered. So there are definitely differences, and the American College of Rheumatology has been working to try to minimize those.
I was interested to follow up on that. Are there any adult rheumatologists involved in the pediatric trials or pediatric quality improvement? Are there, places where they've partnered with the pediatric teams to try and make sure that care is being translated?
We have med-peds people in the field. On a few of these papers, there was named Peter Nigrovic from Boston. He's med-peds, and he's been a major leader in the ACR CARRA and has had a big impact. Teresa Muscardin, who was our fellow here, she was a med-peds fellow, med-peds resident, peds chief resident, med-peds fellow, was at Mayo and is now at NYU, is the the co-leader of the small center group within CARRA. That is the group that facilitates the small centers have a voice in CARRA studies. So there are a number of med-peds people in our field. They haven't directly partnered with medicine programs for the design of any studies. And I don't know, I can't even think of a medical center off the top of my head where a large percentage of the patients are treated by the adult rheumatologist. It tends to be the community physicians, I think. Could be wrong about that, though.
And I just wanted to ask, I know that at one point in time, trying to fund some of these things to get them off the ground has been challenging. What has been your tactic to try and get both the funding from the sponsors as well as from the institution to try and support your efforts?
So PRCSG has industry-sponsored studies, and the budgets for those are usually generous. So Joe helped really put in the infrastructure here, hired Amanda Galster, and Amanda's worked very hard, and she's facilitated us getting part of a coordinator, then a whole coordinator, and now a second coordinator. And so those industry studies are very good for supporting. CARRA pays for the coordinators and the physicians to go to the national meeting every year. It doesn't cover every expense, but it covers your airfare and your hotel if you share a room and the meals during the meetings. So that's underwritten. Some of their budgets for the actual studies, like the registry, they're a little thin, let's say. The PR coin is the one I struggled the most with to get launched. I had a large gap between the time I was involved in quality improvement in the first iteration and then joining this, because there's a $10,000 annual fee. And you see the same thing for other networks that have been similarly built out, like the gastroenterology network. But fortunately, the WASI Foundation allowed us to repurpose some of those funds that we did for more program development, not just the training years of the fellows. So we started with the fellow doing the work, and that was the justification for PR Coin. So we first got approval to do that, then we got approval to continue it so that those funds are facilitating the junior faculty's development and some of the early stage PR Coin work.
Thank you.
I think that's it. Thank you, everyone.
You have been disconnected from the meeting.